My name is Paul Kidwell. I'm with the Connecticut Hospital Association and always appreciate the opportunity to be in front of this committee to testify and answer your questions. Today, I want to touch on three: HB 5054, SB 210, which make changes to the cost growth benchmark, and SB 211, which seeks to study health insurance in the state. CHA opposes those sections of HB 5054 and SB 210 that affect the cost growth benchmark. I think, as you know, CHA and our members have been at the table with the benchmarking process since it was created by executive order in 2020. Our members have served on the varying steering committees and committees that have helped form the benchmark. And so we have a pretty good understanding of the process that has ensued thus far. To that respect, in our mind, before any amendments are made to the existing cost growth benchmark statute or additional authorities are granted to OHS, the real and material deficiencies in the implementation of the cost growth benchmarking process should be addressed. As Senator Huang noted from our testimony, in our view, OHS is yet to implement a reliable data process for accurately assessing performance against the benchmark. If the intent of the benchmarking process is to help guide healthcare policy in our state, then the bare minimum standard for that process must be the use of accurate data. So let me just give you one example. OHS uses data from payers to assess benchmark attainment by large physician group practices, and data from the All Payer Claims database to assess providers that OHS has the authority to describe as key drivers of healthcare spending. In both cases, providers don't have access to the granular level data so that they can confirm OHS's calculations. And OHS's answer to the request that at least the APCD data be made available was answered actually yesterday with an instruction that providers should make a request to for the data through OHS's laborious and oftentimes unsuccessful APCD data request process. If this is going to be a partnership about understanding what the data is, then we think at the minimum the data should be made available to us so we can actually cross-check the assumptions and the calculations that OHS is making that then would have ramifications related to, as this bill proposes, performance improvement plans. Additionally, the benchmark has only been assessed once thus far for 2021. In that case, spending rose 6% from 2020 to 2021. That amount exceeded the benchmark. Taken completely out of context, under this bill, OHS would have had the authority to assess a penalty by imposing a performance improvement plan. Would that have been fair? Our view is that it would have been legal, but certainly not fair, because the year before, in 2020, spending decreased by 3.1%. Why? Because of the impact of COVID in 2020. In 2021, patients came back to get all the care they couldn't get in 2020.
Your 3 minutes is up if you could please.
I'll just conclude by, in thinking about what's before you, would you have preferred that healthcare providers tried to slow spending when patients were coming back for care? Because under this bill, OHS would have been within its right to impose a plan to do just that. I'm happy to engage in many questions that were brought up before that you have today.
Thank you very much for your testimony. I think Representative Wood has some questions.
Hi, Paul. Thank you for being here.
Thank you.
So I just want to go back to the accurate data collection, or the reliable data process that you had referenced. So you were saying that the APCD data goes in from providers, and you're saying you want to then look, you want to see that to make sure it's what? Like what?
The calculations are actually being done correctly. So for example, in a previous job, I did a lot of, every year Medicare comes out with a rule that says, here's what we're going to pay you for the next year. And Medicare gives providers all the data that they've used to make those calculations. And then every year from where I sat, we actually did all the calculations that Medicare did to make sure that the calculations were actually done correctly. And every year we found instances where there were inaccuracies. And then we went to Medicare, to CMS, and said, hey, there are inaccuracies. Can we fix this? We can't do that today with the benchmark. OHS takes the data from the APCD, they draw conclusions from it, present them to us, present them to the committee, present them, and we have no way to determine if they're accurate or not. We don't have the level of granularity to do that. We think that's a bigger, if we want this to be successful over the long term, which we do, then we have to come to some agreement around how can we all assess the same data in the same way to come up with the same answers. And then we can draw our own conclusions from that, but we can't even do that today.
Well, I mean, I think you have ears on this committee that hear you in this aspect. I mean, I think all along have been very excited about the idea of the benchmark, but knowing it's going to take time to like ramp up. I'm going to do what I hate to do, which is say, we always look to Massachusetts.
Yeah.
Does Massachusetts benchmark allow, or the benchmarking process have that reliable data component that you're seeking? Because we're always saying, well, look what Mass did, but we should do what Mass does. I mean, is that something that works?
Massachusetts has a much more robust apparatus in place. They have an entire group of individuals who that's all they do. We don't have the same thing in Connecticut. We have a consultant who does much of the work. And certainly there are wonderful staff at OHS, but they're not doing the work on their own. So the comparison between us and Massachusetts, I think, is leaps and bounds different. Certainly, are we modeling the benchmark off of Massachusetts? In many ways, yes. But as far as the fundamental infrastructure that underpins the benchmark, we are not. Okay, so
if the implementation of the PIP was moved out a few years and you were an active member, you and the entire team were an active member of getting to a point where we have more reliable data, would you be on board with something like that? Or are you opposed to having a performance or PIP?
Yeah, we're certainly opposed putting something in statute and then hoping that the data becomes better by 2026. Absolutely opposed to that. If we get to a comfort level with the data where we can all agree that the APCD data is open, the payer data is available, and we can work together to assess data together, then we should talk about those plans into the future. But right now, the hope that in 2026 we will, or in 2028, that we will be able to create a process that works is we're not there.
I just have one last question. Have you asked OHS for the APCD data to review or compare, and have they said you can't have it, or we don't do it both ways, or
well, for the APCD data, actually yesterday there was a steering committee meeting where this came up, and the answer was either hospitals or I guess CHA could ask for the data through the APCD data process. So that's an application where you specify what you want to use the data for, then that request goes to a committee of the APCD to decide whether or not you can get the data or not. If they say yes, then we get the data and we could then do the study. If they said no, then what? And so it occurs to us that OHS has absolute access to the data, right? They can use it, they can make assumptions, they can make public presentations. We have a 3 or 4 step process by which we would have to go through to get the data. And that seems incongruent to a partnership where we're trying to actually assess things together.
I don't have any further questions. Thank you.
Thank you, Representative Wood. I have any other questions? I have just a quick couple of questions. I was hoping you could help me. You referenced Massachusetts a couple of times, and you referenced a robust apparatus was the word you used, I think. Could you, and you don't have to give me all of it, but could you give me some sense of what you were referring to there when you say a robust apparatus?
So they have an entire a separate entity in Massachusetts that all they do is look at healthcare costs. So if you think about OHS has multiple responsibilities, not just the benchmark. They're responsible for the certificate of need process. They're responsible for overseeing hospital community benefits. They're responsible for overseeing the health estate improvement plan. In Connecticut, with the benchmarking process, we use a consultant to do much of the work of the benchmark. In Massachusetts, they have the Health Policy Commission, they have, and then underneath that, an organization that does all of the analytic work for the benchmark. We don't have that here in Connecticut. My point is, while we are modeling ourselves after Massachusetts, so says OHS, not in every way.
Okay. And that's the approach that you're talking about. It sounds like, and again, don't let me put words in your mouth, correct me if I'm wrong.
Yeah.
It sounds like what you're kind of alluding to is that the responsibilities of OHS in Connecticut are too broad, and they have too many responsibilities to do it well, and we would benefit from having someone that can do the analytical work in-house at OHS.
I think we would benefit on OHS really focusing on the things that it's currently tasked to do and do them well. And certainly we have thoughts about the certificate of need process.
Sure.
And the energy that needs to go into improving that process. We think with the benchmark, there's energy that needs to go into improving the data analytic process before we give now OHS more authority to do other things. So cost and market analysis in the benchmark, performance improvement plans in the benchmark, subpoena power in the benchmark. Those seem overly extensive compared to where we are today.
Okay, that's fair. Thank you. Any other questions? Someone online? No?
Great.
Thank you very much.
Thank you for the opportunity.
Appreciate it.